So Sandra Eismann, Head of Demand and Capacity at NHS England and NHS Improvement. And with me today are Edwin.
Hello, welcome everyone.
And Vanessa.
Hi everyone, welcome for joining us. Thank you for joining us, sorry.
And we're presenting today with Stacey. Stacey.
Hi everyone, yes, I'm an analytics manager at the strategy unit.
Perfect. So today we're going to talk about some modelling at system level and simulation. And what we're going to focusing on today is on two methods. So one is discrete event simulation, which Stacey is going to talk about, and then systems dynamics modelling, which Vanessa will talk to you about. And I'm going to start with a bit of background. So we currently live in a world, and I think some of you have said this before, where it becomes more and more important to look at demand and capacity across the system. Yeah. So what's the difference? You might be familiar with service level demand and capacity planning. Yeah. You have a service in your hospital, and you need to have the right number of outpatient appointments. You need to have the right follow-up appointments, surgery slots, or you need to have enough minutes in terms of your diagnostics to be able to see everybody. Yeah, so that's service level demand and capacity planning, and that ensures that the flow across the pathway, usually traditionally it was in hospitals, but it also can be in the community. It's just we haven't seen that much demand and capacity modelling in the community, but that kind of ensures that the flow of the patient is as good as it can be, and you're using your resources as effectively as it can be. Yeah, so that's the traditional demand and capacity planning, which this team has focused on, and I think a couple of you have mentioned when we were having a chat before we started. So what's different about system level? So system level, you're taking much more of a helicopter view. Yeah, so you're looking at across boundaries, across different organizations, and it allows you to do a number of things now. Number one is it allows you to include population health needs, and especially a prediction around what your the health needs of your population might be in the future. Yeah, because you're looking at a geographical patch. So what's your population now? What are your segmentations? What do you expect in 5, 10, 15 years? So that as we've got that predictive element that you can apply. And secondly, it allows you to actually look across the system and think, right, how can I reallocate my capacity in the system? Where can I use it best? And then you can model different approaches. Yeah. Previously, when you were looking at service level, you were always staying almost within that service level demand and capacity modeling. But this new approach basically allows you to actually think about, can I do a new pathway? And can I allocate my capacity somewhere else? Can I divert my demand somewhere else? Yeah, so it's one of the differences. So system level modeling is a bit more strategic, and it allows you to have that helicopter view. In terms of modelling or analytics, there are different approaches and methods. Just a very quick background. Descriptive analytics on the right-hand side, I'm sure most of you will be familiar with. So these are kind of like your performance indicators. Yeah, very simple analysis, what has happened. What we are actually talking about is much more predictive analytics. Yeah, so what we want to do is we want to project what we know about the past. We want to project that into the future, and we want to play with it. I think Vanessa and Stacey would call it differently. They call it simulation, but essentially you want to play with different parameters and see what happens in terms of your pathway into your population, and what are the effects. So, and discrete event simulation and system dynamics modeling are the two that we're focusing on. They are just part of a range of methods, and they all have their place. But in terms of system level demand and capacity modeling, these are the two approaches that we would emphasize to you today. Anybody feel free to interrupt me if you want to. I'm just going to pause there if there are any questions so far. Okay. So why should you use data to simulate? Well, data actually allows you to do this as a learning tool. And what it does, it improves your collective understanding of the system. So what we see, systems who've applied this method, what we've seen them do this, you need to get together. You need to agree, actually, so what are your strategies, isn't it? Because of everything that you could focus on in your system, what's your strategy and what are your priorities? I think somebody mentioned the reduction of harm earlier on, yeah? So collectively you have to agree what's your priority, what do you want to focus on. Then what you need to agree on, actually, what's the current existing pathways, that how do we provide care at the moment? And you'd think that easy, but that can take a bit of time for everybody in the system to agree what's currently happened. And then what the model allows you to do is, okay, that's the what if scenarios. So let's try to play with different ways of how we could provide that service in the future. And the model allows you to change the different variables, and you can test it on paper, on screen. I'm not telling you anything new. Some systems, data quality can be a challenge in some of the systems. But again, what all of this modeling does, it does improve the understanding of not only what's happening in the system, but it does improve the data quality in the long term. And that's just a quote from Claire. She was one of our partners in Norfolk and Waveney, and she said, I have found that the principles of system dynamics enables us to be able to look at the patient's pathway on one screen and be able to virtually make changes and see the impact on the whole system before making actual physical changes. This enables greater, more open conversations about what is best for the patient and breaking down walls between organisations within the system. Norfolk and Waveney, they're actually one of the case studies, I think, in day 2 or 3 they're presenting. So if you want to know more about what was done in Norfolk and Waveney, do join us for that session. So why should we use a system? So the first question was, why should we use modelling? Because it's safer to do something on screen and test it out in a virtual world before we do something. And the second thing is about why should we use a system level approach? And it allows you to, as I said before, look across organisational boundaries and kind of test out where do you put your capacity and what's the impact on the rest of on the system. You can actually visualise a patient pathway across a whole system, and I'll show that to you in a second. And you can actually reduce healthcare spend because the model can actually tell you which of your interventions might be the most helpful and where you should allocate your resources more effectively. So just to show you what you're actually allowed to model or what the model can take into account, if you were to model everything, you could cover community, non-elective and elective and an inpatient care, and you'd then also think about where do your referrals come from, yeah? So it looks fairly complicated, and this is why I say it takes some time to get together and agree what are actually the actual pathways. But you can create the flow chart, and then the model can actually build that kind of pathway for you. And again, why should we use a system level approach? You can test out the opportunity of doing something or nothing. So just to show you one of the quick output of from one of the model, what it could do. If you were to look into relative change in annual admissions, could be admission for via A&E, whatever it might be, the model allows you to say, if you do nothing, what happens? You could then say, okay, I want to do an intervention in primary care. And as a system, across the system, you would need to decide what that intervention might do. You could do an intervention in secondary care, or you could combine 2 and 3, yeah? And it allows you to play with that different variables, and you can see the cumulative output that it will have on the numbers of patients that you see in the different stages. What also system level modelling allows you to do is it allows you to link up your requirements of your system with workforce planning. Yeah. So, and often for workforce planning, people also use systems dynamics. Yeah. So you look at the number of new trainees that come in, how many drop out, how many progress, how many drop out, how many progress, drop out. Yeah, so that's and that's why it's called systems dynamics, because it's an interactive model where at the different stages you can basically say how many people are dropping out in the system, and then how many have you been left with. Yeah. Before I pass on to Stacey to talk a bit more about discrete event simulation, does anybody have any questions or comments? And just a very brief introduction on what's what and what some of the benefits are.
We've only had one question so far. It was about will the slides be circulated? And yes, they will. We'll be emailing them to you and uploading them alongside the recording. We'll signpost that all to you. But we'll have time also at the end of the session for Q&A and discussion as well. So if you want to have a little ponder about what you're hearing, we can talk about it in more depth then.
There is a hand raised, Sandra. Simon, I think. Sorry, it's gone now.
It's Simone. Sorry. So I was undecided whether to wait to the end, and then I thought I might have forgot what I want to ask at the end. So I'll come in now. So it's Simone Woods. I'm one of the assistant divisional general managers of medicine over at NLAG. And I'm guilty as anybody multitasking, but I kind of popped in on your slide and you were saying obviously about the graph showing you, what the intervention's impact would be. Is it interactive, or do you have to know? Is it so that one, essentially. So you do nothing, and then you've got your intervention in secondary care and combinations of 2 and 3. So do you put something in like you would on the IST tool to basically say, what we're going to say with primary care, and then it predicts the outcome of that? Is it that intuitive?
Yes, but it's actually allows you to do much more. So yes, hold on the thought, Simon, because Vanessa is going to show you what one of the interface of the systems dynamics model will look like.
Okay, brilliant. Thank you.
So hold on to that question. Okay. Anything else? Any clarifying questions before we move on? Okay, Stacey, let me hand over to you.
Great. Okay, guys. So these 4 images depict the kind of keys that I think about when I'm trying to develop a simulation project, be it system dynamics or discrete event simulation. The first one is the clue, and this is about determining when and why we use simulation and what issues you're planning to address. So to you, the project objective might be clear, but what you've got to make sure is that all your decision makers are on the same page. It might seem pretty simple, but often defining the purpose and the objective of your project can take a bit of work, and you can't expect the software to solve all of your problems. So that comes down to being very specific about what the scope is and what you're trying to address. The second one is the cost, not just financial costs, but the impacts of that project. So the cost versus its potential benefit. How and why does it make sense economically to be doing this simulation project? And also things about, are there appropriate alternatives you might use instead? And thinking about when you're assigning resources, you're taking people from doing other work to work on this, and you shouldn't underestimate the time that it takes for the communication between the modeler and the stakeholders to actually develop a simulation model that addresses the problems that people are focusing on. The one in the bottom left that's the commitment. So it's not just about completing the project, it's about completing the project in the right way. Being committed to good project management, getting support from the right people to be involved in the project, and that balance between the modelling and the communicating with people about the priorities and defining the proposed system. And finally, the last one is the courage to make the hard decisions about what to include, what not to include, to challenge overly optimistic timelines, to know when it's appropriate to do the modelling and when it's not, when you should pull back, to have the courage to investigate when you've got issues with the model, and also that bit where you've got to report back unexpected or unwanted results. It might not necessarily show what people think or want the model to show. So whenever I'm planning a successful simulation project, those are the 4 things that I bear in mind that I'm going to have to tackle throughout that project. In terms of discrete event simulation, and what is discrete event simulation? Discrete event simulation is a model, it's a computer model which mimics the operation of a real or a proposed system. And the simulations that we look at are flows of entities through that system in a time-based way. So a DES model will model systems as a network of queues and activities, and where changes in that system occur at discrete points. The objects in the system are distinct individuals. So we might automatically think about patients, but we've also done projects in the past that has been involving, for example, ambulances. And we modelled in a discrete event simulation the impacts on the various trusts across our region around increasing demand for ambulances, and also the change in the clearance times and the handover times at those trusts to work out for the different trusts which ones had the greatest impact. So discrete event simulations, they're stochastic. So the activity durations and the inter-arrival rates that are incorporated in those models include the variation we might see in real life. Those models can account for the utilisation of resources, and we can look at other constraints involved like travel time between activities, and how the components of the system interact with each other as time passes. There's various examples of where discrete event simulation have been used. It's common to see examples from other industries, from banks, from factory production lines, but in health there's some common examples of it being used for staff assignments at hospital or call centres as well. We use them because they're visually impactful, so it helps for stakeholders to be able to see patients flowing through their system, to see where the bottlenecks is, and that in itself generates a conversation. And in the models, as Sandra alluded to, you can experiment with what if in a virtual environment. So if you change the flow of your patients, if you want to investigate what impact does increasing demand have, how do we need to change staff rotas to cope with this, you can do so in that virtual safe environment to see what impact those changes might have. Next slide, please. So this is a little GIF I found on the internet, and I'm sure the person creating the GIF didn't think what they were doing was creating a visualization of a simulation model. Here you've got the little robots doing their individual tasks and the components flowing through that model. And that's what both system dynamics and discrete event simulation try to depict, is the flow that is happening across your system. Next slide, please. So I'm just going to show you a couple of small examples. Can you go back a slide, please?
I'm so sorry, Stacey. I'm getting distracted by the question. Let me give you the slide. This is the right slide. Alex, can you hold on? We talk about softwares in a bit later. But Stacey.
There should be a vaccine centre slide.
Apologies.
Well, there we go. That's it. That's fine. So I've just put some small examples in rather than bigger ones, just because they're easier to talk through. So this is an example of a vaccine centre model that we did in some open source software. The original model was produced to support Wolverhampton when they were developing their vaccine centres and planning their vaccine centres with the GPs that were running them. And what they wanted to do was to use the models to look at things like their car park capacity, to look at managing the lengths of queuing to try and maintain that social distancing in their queues. So it also involved looking at what the capacity was in terms of how many people could they queue in a space and still keep them separate. They wanted to look at the flows of the patients during the different stages, and critically, because the initial rounds of vaccinations were in winter, it was snowing outside, it was the oldest, most vulnerable patients. They wanted to make sure that people were not waiting outside in that weather too long. So we developed this model with them, and it's got various settings that you can adapt and change and use locally, but then we released a general version that's available on the website, and I think Richard's going to talk to you possibly in more detail about their vaccine centre model, so we're not going to linger too much on the detail. If we just have a quick look at the next example, this is another example from the pandemic again. This time we used a discrete event simulation model to look at the impact of increasing phone demand at a practice. So they stopped doing face-to-face appointments except for ones which they'd triaged first. So the first point of contact was always via telephone. They weren't letting people actually physically enter the building. When we were working with the practice, we like to build our models in a participatory way. So it was very iterative, very talking to them in between versions of the model. But when we were asking them what they wanted to achieve, what they wanted to do was be able to answer 95% of their calls within 10 minutes. So through using the telephone extracts from their telephony system and looking at the distributions of the data in that in terms of how long calls take, when calls arrives during the day, the different patterns of people hanging up and calling back. We developed this discrete event simulation model and looked at the utilisation of their staff based on their current rota, and then what would happen if we optimised that rota to try and maximise the number of calls people could take within the same amount of staffing, and also some other scenarios that looked at what happens if demand increased further. What if we limited the calls so that they could only take 60 on a phone line, and then it would give a message saying asking them to call back later. What would happen if they recruited more staff, that sort of thing, which then resulted in them being able to improve their call waiting times. Next slide.
Stacey, you're mentioning Simulate in here. Are there any other
that's one of the pieces of software. The other example was using JamSim, which is an open source version. Both of those are visual. The other software we use is also in R using RSimmer. So there's various different pieces of software. We actually did, sponsored by the Health Foundation, we did a training course that teaches people how to use all three of those. I think Edwin might have the link to that later on. If not, I can provide that to people if people are interested in learning how to use those. Yeah, so why do we do discrete event simulation? Usually it's around looking at the impact of variation, because if we rely on average, sometimes that can be skewed by outliers that aren't necessarily artifacts in the data, and it can cover up those little differences that might have a big meaning, such as the outcomes for patients. It's quite a granular way of modelling, so there is interaction between the different components, and memory of past activity or changes to those objects can be included. It can be used to show impact elsewhere in the system, and to combining the different weights at different stages in the system. It can handle that complexity as well, that multiple branching and combining different pathways where characteristics of patients might send them off down different routes within the system. And as Sandra said earlier, it's a safe environment for us to experiment in. So before we make actual changes, if we want to look at a future system that doesn't exist yet, and also the time to do this, you can either use data from a pre-existing system, or if you're developing a system that doesn't exist, you can then use expert opinion to try and say, well, what if, what might it look like? And I think at that point I'm handing it over to Vanessa to talk about system dynamics in more detail.
I think you do, but before you do, Stacey, can I just ask you, so for people listening, we're talking about system level modelling and about simulation. In a nutshell, when do you use discrete event simulation?
I would say you use it when you're concerned about the variation within your system, and for looking at more operational level things like how many staff to rota on at particular times of the day, it would be extremely useful for.
Okay, thank you very much, Stacey. Before we move on, does anybody else have a question or a comment at this point in time? Okay, then over to you, Vanessa.
Thank you, Sandra. System dynamics and discrete event simulation in the way the modeling process. work is quite similar. It's about engaging with people. It's about building the pathway or the condition of those patients visually, and that helps to improve the learning. The difference is mainly how the patients flow. As Stacey was mentioning, in discrete event simulation is more granular. You can get this to understand what would happen to individual patients or to a specific characteristic of patients. When we are doing system dynamics, is going to give you an overview what would happen to your overall population. It's not going to be focused on what happened to individual patients, and that's, in my opinion, one of the main difference between the two approaches. System dynamics is not going to be the tool of choice when you're interested about what happened to this specific group of patients. Is not going to be system dynamics, the tool of choice. But if the issue you are modeling is suitable for system dynamics, and we are going to have a review of what those issues is more strategic level, you can use system dynamics, and they work. The two approaches, they work in a similar way. You have an inflow, you have a stock, and then you have something leaving that outflow. The difference is more about how the material or the patient in our case flows through that process or through that pathway. With system dynamics, is not individual patients, is a rate, a percentage of patients moving from one part of the system to the other one. Is not a patient in a queue moving if something happens, if we set up the model to move the patient to the next stage. The patients move in a more fluid way. Think opposite to what Stacey presented, like the robot diagram or the robot animation. This is more about like a bathtub. So it's more fluid. There is always something constant getting into that stock, and there is always something constant leaving the stock. If you think of a waiting list, that's what we call a stock in system dynamics, and then you have referrals into that waiting list. There's an inflow, and then we have patients being discharged out of that waiting list. Then we have an outflow. Could you please move, Sandra, the slides? Yeah, so I was mentioning that. Flows is very continuous in system dynamics. When we use system dynamics, it's important to consider that there is lots of connections in that system. So when ICSs are coming together, you have colleagues from the social care sector, then you have primary care, and all of them, acute sector, they are contributing to the same pathway. And we are interested in understanding how those parts of the pathway come together, on how they are connected to each other. That's one of the potential issues, the potential uses for system dynamics is understanding those connections between the different parts of the pathway. So we have an example on the left. The second graph is about population. You can imagine system dynamics for a waiting list, but also if I ask you to think about population in your local area, we have people who are born, and then we have on the right-hand side, we have death. You will be able to estimate the number of people in your local area if you know how many people were born each day or every month, for example, and if you know how many people have passed away, and if you know the initial number of people in your community. And that's the way how it works. It's not about what happened to each individual person in your community. It's about the overall population. And all those connections, we have an example at the bottom about waiting list. The capacity is only going to be free up in a system that in a service, for example, when one patient or patients are leaving the service. So we are only going to be able to admit new patients in our service if all the patients are leaving. And that connection between patients being discharged and new patients being admitted is a flow, and is a connection that you can model using system dynamics. In principle, it sounds easy, but it takes a bit longer to master. There are a couple of software we are going to mention later on that you can use for this. This is a small example of how a model looks like. If we move to the next slide, Sandra, please. It gets a bit more complicated when you start adding in all the parts of that pathway. It's a small graph, but I think you can get what is in there. We have an interplay between emergency beds and elective beds. And we also have a section for the social care sector. Patients are only going to be discharged if beds become available in the social care sector. Sorry, if there are care packages in the social care sector. So it's important that we include that fraction of that pathway in the whole patient pathway. We cannot leave it out when we are planning at an ICS level. If you are thinking about your ICS, you may say, oh, I have some place level data, so I may know what is the incidence of a condition in my community, but I also have all the data that is sitting, for example, in the acute providers, and that's provider level data. You have a range of data sets in there. System dynamics will allow you to use different data sets and put them all together in one single model. It's able to handle different data sets, and you can convert it, and we can help you to understand how that process might happen. Is there a question in there?
Yes, modelling social care complexity, the potential of System Dynamics 2013, who authored this publication. We have a link.
Douglas McKelvey. We can put it in the chat box.
And we have a link later on in the presentation. Vanessa, can I just, something that Simone said early on, and it just chimed with me. She kind of said, is it similar to the input sheet on the current IMS tools? One of the differences to the current service level modelling that we've promoting so far, and I think what we're presenting today is, am I right in saying that because this is a lot more bespoke about what's happening in the system, and every system does it slightly different, that actually for each system or place that you want to model, you would build a bespoke model? And you could determine the parameters of that model, so you can determine what you want to model, and you can also determine what is it that you want to change within the model. So what are your parameters you want to play with, and what are the what-if scenarios you want to come up with?
Yeah, in system dynamics, we don't build models based on what we think the pathway is like. We build the model based on what the issue to be modeled is, if that makes sense. We need to capture how the model is going to be used, and then we develop the model based on that question, if it makes sense. It's in that way that we do the modeling. And the reason for that is because the assumption we are going to make depends on what that question to be answered is, but also what are those different what if questions that you want to try. So we're going to make or build a model that will allow you to play with those variables, and you will see the impact. So defining the issue and defining the what if question should be happening before the first version of that model is available. And in the next slide, I think we have the user interface. Yeah. So this is for workforce. Sandra already mentioned that one in the previous one is about workforce. You can model workforce at a ICS level or for your locality as well. So students can transition to become junior doctors, and then they can become in the model more like senior level or consultants in that model. So for join up workforce planning is also available. It's suitable, sorry. And now the next slide, Sandra, sorry. We have pilot, we have supported one ICS to use system dynamic for their elective recovery plan. That's not for Waveney, and that ICS is going to be presenting that project to you in 2 weeks' time. But we are also now starting to use system dynamics for UEC, for original emergency care services. What we are doing with this new ICS, and it's a project that is just starting, so we cannot document it, we cannot present it to you yet, but aiming to do that in the next few months, is about testing alternative provisions to emergency departments. So what happens if we have a number of services available that patients can be diverted to instead of being presented to the emergency department. And there are specifics. So we are going to start developing the model based on what they decided they wanted to do. What are those different what if questions they are trying to answer? Next slide. So this is how a system dynamics model looks like. For the user is very different and the model that you get for the model developer. The model, you get something that looks like a pathway. For the user, it's just like a dashboard and looks like this for the user, and then you develop it in the way you want to. It's very flexible if you get a good package. And we're going to talk about software now. But next slide, please. This is similar to what we have in our more operational tools is a dashboard, and these are the different variables you would like to test out using the model. So the user interface will allow you to make changes to those assumptions. You run the model, you get an output for those assumptions, and then you change the assumptions and you run it again, and you can run it as many times as you like. What is important to understand is what those assumptions mean in real life. How are we going to implement that if we want the system to behave in this way, if we want our ICS or our population to achieve this? So in terms of software packages, as there were a few questions in there, we are leaving you there. The software that we know. So from the commercial packages, Bensim, Stella, and PowerSims are the more powerful ones. The one that you are seeing here on the screen is Stella. It's very powerful in terms of user interface. Bensim is also very good. There are others that you can use free of charge. There are limitations. Your data won't be confidential. It may be exposed online. And some people like Stacey, she has tried herself doing system dynamics using R or Python. You may get the same outputs, but you don't get the visual. You don't get the pathway in one screen. And that's one of the benefits of helping decision makers to have that conversation, is seeing the pathway in there, seeing how the things connect together, how social care is connected to primary care, and how the decisions that are made in secondary care are affecting services in the community. You want to be able to see patients flowing through the pathway. And if you use R or Python to get those figures, you are not going to be able to have the graphic. You are not going to be able to have those visuals in there. Yeah, next slide. So in summary, and I welcome Stacey you to make comments in here. In literature, you can get, like, usually system dynamics is more for a strategic decision, strategic issues, and then we have discrete event simulation for more operational or tactical issues, but that's a very fine line. It's not like black and white. You can use system dynamics for some operational modeling, or you can use discrete event simulation for strategic decisions as well. So you will have to be careful when you are deciding what approach. And I would be asking you, for example, do you really need to know what happened to individual patients, or you want to have an overview of what happened if you implement something? Go with system dynamics if you want to have a look at the trends if something is implemented in that ICS. Also, if you are looking for long or medium-term planning, is more likely to be system dynamics. If you are more looking at the short term, is likely to be discrete event simulation. If you want to get patient insights, discrete event simulation. If you want to know something about timings when the patient is moving from one part of the system to the next, is more perhaps discrete event simulation. So this is a bit of information that you may need to use when you're choosing your modeling approach. Stacey, do you have any views in there?
Yeah, I mean, I definitely agree with you. There's areas where there's a grey area where you could use one or the other. There's also some instances where you might combine them together and do a hybrid model. And certainly one of the big considerations is, are there elements of the system that don't average out, where that variation would create different outcomes for the patients that you need to be concerned about.
Now that you mentioned hybrid approaches, Frimley case study that's going to be presented to you next week is a hybrid approach. So if you would like to hear about their approach, they are combining actuarial modeling with system dynamics. So that's going to be an example of how a hybrid approach looks like.
Yeah, I guess the other thing to consider is it a variable that you're going to try and optimize, like staffing? So that would be DES, whereas system dynamics would give you more of a higher level. What could happen if you change that variable?
Reassurance for you, we are not making this up. So you have readings in there, and you have the reference where we got all this information from. Happy to share it with you. And this is Douglas McKelvey on the left-hand side for the person who was asking, who's written that document. So what makes a project successful when you are modeling? For me, the experience we have now, because we've been working with ICSs for almost a year now, there needs to be leadership commitment. They need to not only be ready to work on the outputs, on recommendations of that modeling, but also be committed to free up time for analysts. For example, there is commitment that is required for a modeling project. Analysts won't be able to complete a system dynamics model or a discrete event simulation model if that's on top of the workload. They need to have time to be dedicated to this type of project because it's time consuming, and it takes, for a whole ICS system dynamics model that we have done with Norfolk and Waveney, it took us 3 months to get there. So it's not a full-time job for one person, but there needs to be commitment to support analysts to do this type of modeling. But it's not an analytical task. It shouldn't be centered, or it shouldn't be led by analysts. It has to be operational engagement in there. There needs to be leadership from an SRO, and that's something that we really encourage to have in any modeling project. That is not a silo work. It has to be different parts, not only parts of the pathway, different sectors, but also different roles. In our example with Norfolk and Waveney, we have an SRO sponsoring the project, but we also have a technical lead. He is the head of analytics for the whole ICS. He was leading the project, and then we have a elective care recovery lead for the whole ICS, and the two of them were co-leading the project. It's not a technical task only. And they were supporting the analysts. They were having the conversation with the modelers very often, and they were also in charge of communicating and engaging with operational colleagues, with clinicians who were meant to act on the recommendations of that modeling. So it's not only about the technical skills for the analyst or for the modeler to be able to use a software. It's about the whole picture that you have to take into account. If the issue is not clear from the very beginning, you are going to have to reflect back and then to redefine that model, and that model draft needs to change. So flexibility is important, but also when you are presenting, even if the issue was clear from the very beginning, when you are presenting the outputs of your first model draft to a stakeholder, they may think of something is important and we haven't covered it. So the model and the modeling team need to be able to be flexible and to adapt to the needs of those stakeholders as the project is completed. That's it from me, I think so.
I think
I would just add to that very quickly is that from same sort of experience as Vanessa, is that projects are far more successful when you do them in a participative way with stakeholders. There's various approaches out there that can help you, model building techniques for system dynamics, party sim techniques for the discrete event simulation, that bring those stakeholders together to do this modelling. It's not done in isolation in a closed room.